We've just had the opportunity of seeing three different national approaches to monitoring serosurveillance across the pandemic and before on all sorts of other issues as well. This session, we're going to look at cross-country opportunities for serosurveillance analysis. And so we have a great set of presenters. We have Dr. Isabel Bergiri, who's going to join us virtually. She works with Maria van Kerkhove as an infectious disease epidemiologist at the World Health Organization, and she has been leading the UNITY studies in the context of the COVID-19 pandemic. We have here in the room, we have Dr. Thomas Janusz, who's an infectious diseases epidemiologist and clinical scientist, as well as an associate professor in the Department of Epidemiology at the Colorado School of Public Health. Thomas, welcome. And then we have Mairead Whalen and Harriet Ware. Mairead is at the University of Calgary, and Harriet is in British Columbia, and both of them have been leading the SeroTracker, which was mentioned earlier by Maria van Kerkhove. So you're welcome to come to the panel, and I believe we are beginning with Thomas. Yes. Okay, Thomas, come, please. And when is Isabel coming in? Okay, so she'll go next. Great, thanks. This is your clicker, the big green button.
Okay.
Goes forward.
Okay, thanks everyone for the invitation. So I'm going to share with you three examples or three case scenarios of our work that are on different levels, but all of them cross-country comparisons. One is the Gates-funded project on the Africa serology platform for emerging and new infections, Aspen ID. Then EC-funded project Recoded and Contagio with specific tasks on harmonization and standardization of serological data sets. And last but not least, using serology in a specific example as a proxy for population immunity and assessing vulnerability for future outbreaks for Zika in this case. So the first one is this Africa Seroprevalence platform funded by the Bill and Melinda Gates Foundation. So it's in a pilot phase right now. There are existing population-based sampling studies, and they are complemented with a serosurveillance component, some of them using filter paper blood spots, and they're based on a Luminex multi-pathogen platform. And our expertise at the Colorado School of Public Health in this context is on harmonization of core data dictionaries, on the agreement of a priority pathogen list, on the management of supply chain and standardization of antigen sourcing and preparation, and on the assistance with the pre-processing of the laboratory data using our Shiny apps. And that is in conjunction also with the Sero Summit that Bill Moss and Andrea Castellan yesterday presented. So there's going to be a follow-up summit this year, they told us yesterday, and that kind of effort is a subgroup of the countries that are represented in that Serosurveillance Summit. So right now we have Sierra Leone, Kenya, Malawi, South Africa as pilot countries, and soon to join will be Mozambique and Bangladesh. And one of the efforts also that is supported by the Gates Foundation is a new course, Immunology for Public Health and Serosurveillance. There was perceived need to provide capacity building, especially in sub-Saharan Africa, on the role of immunology in the context of public health and serosurveillance, and that has been taken up with quite some enthusiasm on their side. So here I'm just briefly showing you this pathogen priority list, which was built up bottom up, looking at the needs in each of the countries, having them discuss their priority lists also with the local ministries of health. And that is the first list that we are working with, which, of course, you can ask now, why is Mpox not on there, or why is pathogen X not on there? But it's a list that is going to evolve. Of course, there is a lot of discussion once you start with it, because everyone has their favorite pathogens, but we need to start with something because of the antigen sourcing and supply chain component, and really making sure that for those first set of pathogens, we have a viable supply chain. And that all comes back to standardization and comparability upstream. Okay, briefly switching gears, the Recoded project, EC-funded project that I coordinated, that just finished. It stands for Reconciliation of Cohort Data for Infectious Diseases. And what we see here is also that there is kind of an interaction between acute febrile illness cohort data and seroprevalence data. And that was visible also when Maria van Kerkhoff presented all these Unity protocols. Some of them are more on the acute febrile illness characterization end, and some of them are more on the strictly seroepi end. Within this, and we had partners from Canada, by the way. So McGill was a partner, and the Malmström research unit here at McGill, and University of British Columbia, as well as McMaster in Ontario. And that was part of the EU CAN calls that were launched in 2019. So in this, we have one work package on COVID research response and a task on the harmonization of seroprevalence data for COVID-19 and generation of a seroprevalence map for Europe. And then this kind of legacy was continued, or is continued now in this project cohort network to be activated globally in outbreaks out of Heidelberg University, but with Colorado as a partner again. And we have one task on virtual federated biorepositories and their important role in the standardization. So I'll come back to that shortly. So within these two projects, really the serological component is on how to compare serological data across time and space, and all the heterogeneities we have to deal with. And I just put this name bridging studies out there. I have another slide. I don't have time to go through that in detail. If there are some questions later, I can go in more detail on that. But I just put two publications there that we produced with the SeroTracker team. Then in the middle, there's all the efforts on pooled cohort natural history data. And then on the right, you see the virtual federated biorepository that we support with these two projects, but it really is taking on a separate role itself, growing bigger and bigger. So right now it's a pilot phase, the so-called 10 by 10. So 10 sites will provide 10 ml of with 10 samples with 10 milliliters each of healthy, normal, whatever that is. And that already starts a discussion for those who are in this field, what they consider healthy or normal. And we have gone through a Delphi process about benefits and governance of such a kind of grassroots virtual federated biorepository. So this is the bridging studies, and I'm going to switch this, or go through this a little faster because I don't have time for going through all the details. Actually, I'm only at 3 minutes. Anyway, so this third example I'm going to talk about is assessing vulnerability for future Zika virus outbreaks using expected seroprevalence based on environmental suitability of transmission. So we did a systematic review of Zika seroprevalence data, which is not so much work. There wasn't only a few hundred publications out there. After the epidemic in South America and any time for Africa, and excluded symptomatic data sets, and the final data set for analysis included around 48 studies, but some of them had more than one location. And what you can see here is the map with all the seroprevalence studies we included, their circle size according to sample size, and the different serological platforms that were used. So ELISA or multi-immunoassays, bead assays, or some kind of VNTs or hemagglutination assays. So then we combine this with a published map on environmental suitability that was produced as a part of the IDEMS consortium on dengue, or later on Zika as well. And so this shows a heat map with the highest probability, it's between 1 and 0, as dark red, and lower probability in blue. So now we combine this, if you want, expected versus observed. So the expected seroprevalence should be high in the range of the herd immunization threshold in the areas with highest environmental suitability. And the herd immunization threshold we learned for Zika was around 65%. So this is plotting seroprevalence against environmental suitability. What you can see is in the right lower corner, you have high environmental suitability and rather low seroprevalence. And the borders here kind of arbitrarily placed, but what you can see is there's a high number of locations that have a discrepancy between expected seroprevalence because environmental suitability is high and lower seroprevalence, which is a crude measure, but it's kind of trying to get at this vulnerability for future outbreaks. So this is under review currently, will be published soon, and is one example how we can try to use seroprevalence studies to get at the vulnerability for future outbreaks. Well, and so what's next? For the Africa Seroprevalence Platform, we are going to extend. We were working on a pilot dashboard. We are preparing for the Serosurveillance Summit in 2024. In the Recoded Contagio projects, we are working on that cohort data sharing platform and discussing an extension also for seroprevalence data. And for the seroprevalence to evaluate vulnerability, we are working with SeroTracker. We have now downloaded additional data sets and on other arboviruses, and the extension, and Merit will talk about that more, will be an ArboTracker website. So thank you very much, and I'll be able to answer more questions if there are questions around the bridging studies later.
Thank you. So thank you so much, Thomas. You're perfectly on time, which should allow us time for questions as well. We're going to now go virtual, and we have Isabel joining us. So over to you, Isabel. And hopefully
Sure.
we've got the enabled share screen.
Just checking if you can see my screen and my slides. Not yet. Can you see them?
Yep, coming up. Yep, we see them perfectly now. Great. Thank you.
Okay. Thank you very much. So I'm Dr. Isabelle Bergerie. I'm working, so you've seen Maria, my manager. I've been working with Maria during the COVID-19 pandemic, and I will give you a bit more on the Unity studies, and perhaps I've tried to extract what could benefit your future MANET, and tell you a little bit more about how globally we can all kind of participate in this global effort to be able to take much more evidence-informed decision, let's say, for the next pandemic. So Maria has already told you a little bit about it. I will just want, oh, my slide set are strange here. Just want to put you back in terms of the definition of what it is. It's about all the investigation and studies. So for us, we are placing for sure seroprevalence. It's easy. It's inside surveillance system, but sometimes cross-sectional serosurvey are considered as research in some of the countries, and I will tell you a little bit more about why this is important. It's not only taken as a research project. So why we called it Unity? Because it was really this standardized approach, being able to compare apples with apples, but really to take action. And for us as WHO, we are really working towards capacity building the low middle income country to do the same kind of serosurveillance studies or put serosurveillance system in place as high income country do them. So for your information, serosurveillance was one of the 10 protocols we have had during COVID time. And to state a bit the scene here, because I'm here also to advocate for you, Canadian colleagues, to join us in this global effort. What WHO is envisaging is this creation of a really operational network of sites, not losing the momentum of what we managed to build during COVID time. And we want a small but well capacity built network of sites able to conduct high quality standardized investigation and study, including any serosurveillance study for evidence informed decision making. And what we have on top of that is the equity pieces, because Mairead, I think I had already a talk, and Ariet, we globally we were really not good at making global informed decision, because like half or more of the world were not providing data that were robust enough, especially on seroprevalence. So you've seen this kind of insignia. We are trying to explain also simply how those serosurveillance can kind of unlock some of the, let's say, scientific riddles we have faced. And also we are putting us in place also all the studies along the pandemic continuum there. So there are things that we need to do in the interpandemic period. And there are also some of the serosurvey or serosurveillance system needs to put in place differently at different time of the pandemic continuum. During the COVID-19 pandemic, as it was the case also for the 2009 influenza pandemic, you see the disease burden pyramid on the right, the infected portion of the population, the robustness of the epiparameter for this species of the pyramid was the one that was sometimes not the best one, because there was low investment, or it was thought, at least at the global level, that it was requiring so much resources that it was sometimes not worth in the middle of the pandemic. Thus, the importance of being ready in the interpandemic mode, and it is exactly what you're doing in Canada and other countries in Europe are doing that. I've seen you have also our Norwegian colleague invited there. So quickly coming back to COVID, Maria's talked to you about it. We see also serosurveillance as part of this mosaic of different surveillance system and studies. Serosurveillance should be also analyzed, should be integrated, it should talk to the other surveillance system, so that again, the proper action, the proper decision could be made. So definitively seroprevalence was one of the most used protocols in the world globally. You see on the right the 3 meta-analyses we produced. 2 of them were done together with SeroTracker. And just to acknowledge here the very good collaboration we have had, and thank you also to Public Health Agency Canada, who also helped and supported and provided data for Canada there. And also equity matters. I've looked at some of the presentation here. There are a lot of projects in different parts of the world, but there is a need for connecting all those dots, because sometimes some of the projects are donor-driven or partner-driven, and they tend not to align, to have their own agenda. And then globally, at the global level, when the SAGE, the Strategic Advisory Group on Immunization, needs to take decision, for example, on COVID vaccination, based on seroprevalence data, other data sources, then it's not comparable. And then there are two different ways of doing things. And then globally, all of us as the global community, it doesn't make our work really easy. So insisting also that you see the map as of 31 December 2021, 103 member states have started to implement at least one unity aligned protocol. And just to let you know that it's possible also in low middle income countries, even if they are not supported by high income university, to do quality sero survey or run longitudinal sero studies, example Mongolia. So this is possible, but we need as a global community to really support this effort. Zero Tracker will have shown you, this is what we ended up working with you also, a joint dashboard there. It was not existing, it was not possible at WHO for various reasons, because of the flexibility, the agility of Zero Tracker and all those supported it. This was possible in a record time, and we are co-branding this dashboard. Just to let you know, Zero Surveillance for sure is not new, and especially on the influenza side, it started with influenza with concise network. So I will really advocate for also Canada to join the concise effort, the consortium for seroep investigation. It was really for influenza, but now it will be extended. Ben Cowlin from Hong Kong University is the chair of the secretariat. Maria was the epi lead on that one, and I think perhaps some of the laboratory leads are currently on this call. I want also to perhaps something that you may want to read to develop further the EMANET is this external independent evaluation. The external evaluator published a paper. You have the link here. And I think you need to think about serosurveillance not only on the scientific side, because this is sometimes not the science that is more difficult. This is much more how the program is constructed, the facilitation of things, the management, the timely financial investment in there that makes the difference. At least that is what we experience when we have had to ship plenty of zero assay to countries like Somalia or countries who have had, no easy way to reach, no easy flight, and that was an issue there. The key findings and the key barrier for usefulness, perhaps that will be helpful for you also. This is a global view, so perhaps some of it is not really important for Kenya, but it was the study and the result sharing. A lot of countries in the world have had really good data, but they were whether not allowed to share them, or there was not the data platform to be able to share them, or there was a resistance to share. And I will be frank with you, because some high-income countries behind it wanted to have high-impact paper published. So for us, this is critical in terms of global goods and being able to really tackle the next pandemic. This is something we need to really seriously work on. Then in terms of standardization and completeness. So still, despite the protocol were here, despite there were like a really global help desk, any country could contact us for various expertise there. There was still a lot of variation in the method used. It's requiring a lot of time, but we try to centralize that and having this help desk ready to answer any scientific or non-scientific questions for the countries. Then the third barrier were the communication of the findings. I think as scientists, we need to be better at translating science for policymakers. And convincing them, and human beings do not like uncertainty, but for us, many, we know what does it mean. But I think there is a need here for us to be better at that one. And then for sure, the governance. The governance was, I mean, it's something in the background, but if the right governance is not here, zero surveillance doesn't work. And the value for money, and I will add about the sustainability of this. Definitively, in most of the low middle income countries, sometimes there is an investment by partner, but because they are injecting too much and too rapidly and not thinking about sustainability since the beginning of the project, then if they leave, or if there is a change in management or whatsoever, everything is falling apart. So we need to be really serious about that, trying to make all this sustainable and demonstrate the value for money of zero surveillance. But the good news in terms of the added value for zero surveillance globally during COVID-19 is that through this external evaluation, 90% of the respondents agree that the initiative should continue. So countries saw some value to it. Now it's how to make it really far better next time. But at least the momentum is here. We have partnered with us, and we have partnered with a lot of you. I recognize some of the names here. For the future direction, this is the key headlines here. We are started again back to the key question that policymakers will want to answer during the next pandemic, and even in the epidemic period. The key protocol that needs to be developed, and seroprevalence is one of them. It's already on the WHO website, and more is to be developed. And then the key sites around the world that will be able to collaborate timely and be at the ready for the next pandemic with WHO. We also, you see my little man here, a protocol that stays in the shelves, a protocol that is not exercised every day, even part of this protocol. It means that the countries will not be ready, or the sites in your country will not be ready to really timely deliver a result and have all the right proper processes in place. We are also, as many of you, thinking about extending that. Maria has already talked to you about it. We are working with SeroTracker also together with the Colorado University. We want to expand to a pathogen with other mode of transmission, the non-respiratory one like monkeypox and arboviruses. And this is progressing. So this is a good news. I will stop here. I hope this global overview, quick one, because I could talk about it for hours, will have helped a bit your strategic thinking about it. And I'm happy to say that in the next acknowledgement slide, I will be able to acknowledge some more of you there. So thank you very much. Merci beaucoup. Au revoir.
Thank you, Isabelle. Excellent. We're glad to see that you're throwing in health promotion linked to the continuity of seroprevalence studies, a little bit of weightlifting every day. So we're going to switch now to the SeroTracker, and we have Mairead and Herod. Over to you.
I'll start us off. So pleased to be chatting with you all today for talking about really our global effort and cross-country opportunities for serosurveillance that we conducted through SeroTracker. Okay, so briefly what we're going to talk about how we built SeroTracker, what we did for that, some insights and lessons from our work and our cross-country analyses, and then the Canadian context and value, bringing that impact to a global stage and a bit of the future. So starting off with what we did. So bringing us back to the start of the pandemic, there was a lot of really valuable seroprevalence data that was being produced across Canada and around the world, but the issue was that once this data was published in static journals and institutional reports, it was scattered and then therefore really difficult to synthesize and actually use for public health decision-making in a meaningful way. So what we did to address this problem in collaboration, working with CITF, was to build SeroTracker with the goal of creating a centralized and synthesized, fully accessible resource online in a meaningful way to bring this seroprevalence data to light. So we did this backed by the largest living systematic review of its kind. We identified serosurvey sources weekly. We screened over hundreds of thousands of abstracts, and now our dashboard includes over 4,000 studies, including data from 38 million participants worldwide. Now, what makes us unique is that we then pipelined all of this information to our public dashboard and repository. This is a video, maybe it will play, maybe it won't, but you can access it on serotracker.com to play around with all of this. So we displayed each of these studies online, and you can filter through, interact with it, and then download our full data set publicly and accessible, as well as some of our interactive analyses on our Analyze tab. So in bringing together this seroprevalence data on a global stage brought user value not only for Canada, but global users as well. So through research and action, we collaborated with several different institutes beyond the Canadian level, including the Robert Koch Institute in Germany, CDC. Of course, on the global level, you've heard a lot about so far from Isabelle and Maria on our WHO collaboration. We'll get into the results of that later. But our data was used to identify gaps in immunity, identify vaccine trial sites, and then bridged its way into journalism, where because our data was publicly accessible, it was used in op-ed and cuts of data by the New York Times, The Economist, and others. looking into more insights and lessons from our work. So one of the really interesting things beyond looking at actual seroprevalence estimates, we were able to look at methodology and the field as a whole. So one of the main challenges we encountered in SeroTracker, especially during an emergency, very urgent pandemic response, was publication delay and how that impacted availability of seroprevalence results. So we ran an analysis on really how quickly it took us to be able to publish and have this data accessible. So we found that in between the timing between the first sample was collected and the results were actually available publicly to use was about 5 months. So you can imagine that during an urgent pandemic, Omicron comes around quite rapidly, suddenly all of the data is obsolete. We need it now, and it's going to take about 5 to 6 months to produce a meaningful global analyses on this front. So some of these takeaway lessons, bringing this back to Haymanet and Canadian context and elsewhere, what's really important here, we found there's a need for these modern approaches to streamlined, accessible, and standardized seroprevalence studies beyond SARS-CoV-2 into multiple pathogens where a similar approach is meaningful. Timeliness and access to this data is really important, so exploring how we can have a situation where you could have more immediate or submitted access to data, tailored bibliometrics, plug-and-play visualizations and mapping tools were hugely important. And then continuing closely in collaboration and participation with experts globally and in Canada. I think there's a gap often in between the data needs and what's actually happening in labs, but coordinating that on a really close level can bring the standardization really all the way from start to finish. So getting into the results, I'm just going to stop briefly here and look back at our analyses that we did looking at seroprevalence studies in 2020. This is a little snapshot of the data we collected in SeroTracker and all of the results that are available there. I won't dive too far into this, but just to note that at the end of 2020, we identified that global seroprevalence in the general population was hovering about 3 to 4%. This was echoed in Tim's analyses or a presentation he gave yesterday, where we found seroprevalence in Canada around 1% was also really quite low, showing a big gap in immunity from 2020 onwards. I'm going to hand it over to Harriet now to dive into our more WHO-related analyses. From here on, this is when we embarked on our collaboration with them and some of the results we found there.
Great, thanks. So yeah, this is some of our later work in partnership with WHO, where we focused on large scope, general population, high quality seroprevalence studies aligned with the Unity protocol that Isabel mentioned. Using this data, we meta-analyzed seroprevalence by month and mapped the changes in seroprevalence over time to look at the trends by region. And we found considerable variation by WHO region as shown here, both over time and in, so looking at sort of the first year post mass vaccination, we isolated seroprevalence from infection based on the assay and vaccines used in the study and country. And so we showed that really the increases in seroprevalence during that time really being driven by vaccination in the regions on the right, Western Pacific and Europe and America's high income, whereas on the left still continue to be driven by infection and transmission. So another interesting result we found, we compared the seroprevalence or the infections from seroprevalence data to the confirmed COVID cases. And this result is from late 2021, just before Omicron. We showed that COVID cases underestimated infections by 10 times. And this also varied by region considerably from about 2 to 1 in the Americas high income, which is still missing quite a lot of cases, all the way to 177 to 1 in the African region. And this type of result formed a crucial part of our understanding of COVID-19 epidemiology, especially in low and middle income countries where the case data was was less reliable and set the context for decision-making on the global stage. So now I'll speak a bit to the Canadian context and value, especially looking at the late-stage pandemic and multi-pathogen work. With our global database, one question we get asked a lot is what can we learn from 2023 seroprevalence data? And the answer right now is actually not much, because we found in late 2023 in our systematic review that most countries had either stopped sampling or stopped publishing seroprevalence data or seroprevalence studies in 2023, with the exception of the ongoing Canadian Blood Services surveys in Canada. So that's shown here from the CITF website. And so we believe, and I think we saw yesterday, there's still utility in SARS-CoV-2 serosurveillance 2024 and onward. And so we think Canada can be an example for other countries in this regard, especially when you're able to look at differences by age and risk groups, and instead of just assuming everything is 100% now. So I also wanted to touch on our multi-pathogen work. So Thomas spoke to some of the really interesting work in arbovirus seroprevalence, and so we've partnered with his team to take a systematic review they did on 6 different arboviruses and create a new website to track that, similar to Serotracker, but with different mapping and visualization tools more tailored to arboviruses. So this is underway, hoping to launch in the spring or summer of this year, and we're also thinking about how that type of approach can be adapted for other pathogens as well. And yeah, this is just again echoing our partnerships on with Serotracker and Canada on the global stage, and with WHO as well. And since I'm almost out of time, I just want to thank our team and thank the CITF for funding us. And yeah, thank you all for listening.
Okay, so you've been sort of drinking from the fire hose this morning, and apologies, but it's been, I think, pretty stimulating and nourishing, at least in my humble perspective. So the floor is open for questions, and just on the questions, we will circulate first a list of all participants in email, because I know there are people who would like to ask our 3 participants who were online earlier. I'm not sure if they're still online, but if they are, then we might be able to get a question to them as well. Please.
Hi, thank you. So my question is first to Mairead and Harriet around Serotracker, which, by the way, is just so impressive. So really, thank you for that work. And it's so great to hear that you're expanding to other pathogens. So as you were talking, from the beginning, I was sort of thinking about, and you did allude to it, is that Serotracker can also identify gaps in knowledge. And I think that's actually equally as valuable as synthesizing the knowledge that is found by Serotracker. So now with your collaborations with the WHO and others, how are you planning to sort of summarize that data into calls for action to do more work in, broader geographical regions and or also even, specific populations and smaller geographic regions?
That's a great question. And can everyone hear me? Okay, great. So we're actually planning on updating our global meta-analyses into 2023. Although, as Harriet mentioned, the actual 2023 data that we have is quite scant. It's mainly really the CBS studies in Canada. But we've updated our search. Hopefully we'll get a few more in there. And our main goal really is to highlight what is that continued use and utility of COVID-19 specific studies on seroprevalence, and then really what are the gaps. So I think in doing that and highlighting actually how few of these studies have been sustained past 2022 highlights a really important gap in how important it is to continue maintaining that capacity. And so, yeah, and then with our earlier data also, we were able to identify gaps in immunity, which is another, when you have robust data and are able to do that, I think that's hugely important. So hopefully we'll be able to continue highlighting things like that as we continue to work in arboviruses as well. I think there's a lot of potential there to identify gaps in, from what we've heard so far in our arbovirus collaborators, for example, there's a huge gap in understanding arbovirus diagnoses in Africa. So using our data ideally to highlight just how much we're missing would be great. But Elsie, do you have anything to add?
Yeah, not really. I think, yeah, we'll continue to try to identify gaps, and even in our first global meta-analysis, there were still countries with no data, so we sort of pointed that out when we did our regional estimates, that this is the best we can do, but it's not completely representative, and so yeah, we'll continue to do that going forward.
Great.
Outstanding work. Thank you so much. So thinking about the future and how to take action, I'm thinking about we develop tools, but then we want to make them available and used. So I would like to, ask the panel about the strategies for promoting the use of the protocols, the templates. How are they adopted? There was a great adoption, but maybe you want to do even further so we don't have to always reinvent the wheel. And then I'm thinking about Zero Tracker, and with all that compilation, are there any plans or current communications with the journals to ensure some maybe implementation of guidelines so the data comes in an ideal format for publication? So I'm just thinking, kind of for the future.
Great, thanks. Anybody want to take those?
So
Isabel?
first-
Thomas, why don't you go, and then Isabel will get you next. Go ahead, Thomas.
I think there's two parts to that question. So how can we ensure that future serological studies are more comparable to each other? And then how can we make efforts to put heterogeneous serological studies from the past in the same framework so that they can be compared to each other if this data is still valid for us. And so we are trying to work on both ends, but there are different exercises or different efforts. For the future, I think the Luminex platform currently is the platform that many think it's the go-to platform, where there's also a lot of funding available, and that should make it easier to compare data across time and across geography. For the past, I think we will have to live with some uncertainties, but we are trying to work on some mechanisms, adaptation tools from a biostatistical or informatics point of view, how the studies from the past can be better compared against each other, but there will remain some uncertainty to that.
Great, thanks. Isabel?
Yes, perhaps for the first part, which is much more like the plan for sustainability and how we want to move ahead globally, the plan is really to try. You may have heard that the IHR, International Health Regulation, are currently in the amendment process, but also there is a pandemic accord that is negotiated, and a lot of tools and also agreement will be made between countries to really move ahead with, especially this result sharing. And to be honest, I will be a bit strong about this. I don't count on the peer-reviewed journal to help us further on that one. I really count much more on us, the global scientific community, to find ways to collaborate ourselves and to have, like the Zero Tracker data platform, a tool like this, when we can freely share between scientists and things like this. But we need also to ensure that there is a like, for example, data sharing agreement in place in the interpandemic period to allow that. You cannot imagine the number of very good data from low middle income countries. I'm taking an example in a country in Africa where the president died of COVID, and the results of some of the Serosurvey were here, but never able to be shared because there was a deny that COVID was affecting the country. So it's really, for me, it's a simple solution. Let's collaborate between us scientists and find a solution, and don't necessarily wait for others to find solution for us, and just also maintain this put things much more transparent, and also for the country to see the benefits, because sometimes countries do not see the benefit for their national population. when they share data with the global community, when they share data with the neighboring countries. So this is also ourselves to be able to better market how we can win this win-win approach of it.
Thanks.
Mairead and Harry brought up an interesting point. You mentioned that as of 2023, I think Canada is one of the few places that's actually tracking COVID serology. And I guess the question I had back to you was, given that over the last 20 years, we've now had 3 interesting engagements with a beta coronavirus, do you think that there's value in sporadic serologic assessment of at least the genus beta coronavirus, allowing for some species change?
Yeah, absolutely. I think that's really a huge message of this meeting, is that having a system in place where we can do passive surveillance and looking into these different shifting viruses and how they may emerge would add huge value to both a Canadian and a global context, and being able to, you know, assess beyond what's already happened with SARS-CoV-2, how that disease may be shifting and how others might be emerging at the same time. So yes, I think so, yeah.
So I'm just going to take the chair's prerogative to jump in on that, because it was one of my questions as well. And I think it raises the issue. We had the wonderful presentation from Norway, where they've had influenza surveillance through serology since before I was born, in the 1970s. That has massive longitudinal value in terms of understanding change over time. And so I think this issue of getting beyond the fly and die of a pandemic and understanding how to sustain core functioning, core surveillance, which may not have the same intensity, but still provides that longitudinality, I think is really very important for us. And one of the things that I think also, I'll be direct here, I think we have an acute infection detection bias in our systems. And when that system got overwhelmed, which it did with Omicron in 2022, people thought, well, it doesn't matter anymore. And it was also the time when pandemic fatigue was setting in, and people said, like, okay, well, you know, here we go with another round. Well, the reality is, in 2022 in Canada, SARS-CoV-2 was the 3rd leading cause of death. All right? So it's not as if because it wasn't, it had a lower fatality rate, or it was less pathologic in terms of the Omicron variant. The absolute numbers of people that were affected meant that even with lower fatality rates, we still had a major, I don't know how anyone could not consider that to be a major public health problem. And so this is, again, if you, I think the value and what I'm picking up is the concern. Now, part of that concern might have also been that the serology systems were only geared to anti-spike detection. And therefore, there was very difficult, as we heard from the REACT study this morning, to pick up infection-acquired immunity in a lot of systems. So that may have also been another explanation, but I think this is an important one. I'd like to ask Tomas, there are 2 things that you mentioned, and I'd just like a little bit more detail on them, if you could. The idea of a virtual federated biorepository, number 1. How does that work? Because you know, Isabel was saying we're going to be sharing systems. What does it look like? How do we manage that across jurisdictions? Not the least of which are 13 jurisdictions in Canada that have difficulty sharing anything. So that's a within-country problem. And then the other thing that, if you have a couple of seconds to give a little more sense of, and this is perhaps part of the arbovirus tracker work, but what are the mechanisms for projecting vulnerability for the future? How are we going to develop heat maps, which are going to give us a sense of where we may be vulnerable or at high risk moving forward? So just a few thoughts on those issues would be great.
Yeah, thanks. So number one, the Virtual Federated Biorepository. This is spearheaded by my colleague Mei Chu. And she had this idea for many years, and now has come the opportunity to put it at least partly into practice. And it's a coalition of the willing, if you want. So it's those who are and want to share specimens. They're involved right now, and that circle is growing. There's quite a lot of enthusiasm to become involved. And the idea is that you have samples that you keep locally, but you're ready to share when the opportunity arises or if there is need for those samples. And these samples right now is the normal and healthy samples, and then we will go to the next stage with characterizing specific pathogens or specific opportunities where samples are needed. And the sharing mechanism for these samples, yet to be defined in more detail, is that there should be a sharing mechanism for academics at one side and maybe for diagnostic developers at the other side, especially looking at the need to have early diagnostics available when the next epidemic comes. And that has been repeatedly phrased as a really big barrier for diagnostic developers, especially for small companies or small startups, to have samples that are well clinically characterized. And so that's something we are trying to do there. I'm going to stop there. And the next question, how do we characterize vulnerability? So we are making a first attempt, which I think is coarse, just comparing environmental suitability versus seroprevalence and looking at the herd immunization threshold that supposedly, if there's high transmission, that should be reached in no time for Zika because it was so fast. Still, like, we don't understand, I would claim, that as an infection that has risen so fast in a time window and decreased that we were almost not able to catch it with our natural history and pregnant women cohorts, because the time we went there and set up our cohorts, it was almost gone. We were all at the tail end. We don't have enough cases. We can't do the characterization of the risk factors as we need to. So at the same time, there's many places 200 kilometers away from the coast in Brazil, mid-sized towns that have single-digit seroprevalence. How do we put this together? I don't have an answer, but for me it's clear that there is something we need to understand, and we need to put it in the framework of vulnerability to future outbreak. It's not a question of if, it's a question of when the next outbreak is going to come there. So we are trying to get at that with this first course map looking at environmental suitability, but I think we still have a way to go as a community to define vulnerability for future outbreaks, but I think seroprevalence has a major role to play in this assessment.
Great, thanks. And maybe in thinking about that is that the seroprevalence gives sense of immunity across multiple pathogens, because that's also going to be an increasingly important part of that. So very interesting work. We got just a couple more minutes. I'm not seeing more questions here, but if there are, please stop me. I'd like to, Isabel, just get your sense on, first of all, it's great that there was the independent evaluation, and it looks as if it provided some good insights on how you can strengthen your work. As an economist, I'm particularly interested in value for money. And I noted that your boss stated earlier that she felt that despite a lot of people complaining that pandemics don't represent a viable market, she was impressed by her stockbroker's reports on how her investment portfolio improved remarkably during the pandemic. But it is the issue of what are in value for money? Where are the issues related to finding financing that goes beyond the acute phase? Number one. Number two, perhaps related to that, we've seen this morning examples of serosurveillance being undertaken through hospital residual bloods in Norway and through the biobank in the Netherlands, and providing longitudinality over time. To what extent are assets or resources in countries like blood banks part of that value for money equation? And in your work in the Unity studies, do you have something which is working with these institutions that represent important sources of residual blood and that could be part of your Unity study network?
Yeah, sure. So to tackle the first question, this is the challenging question because last pandemic, 2009 influenza pandemic, we felt like we don't want the same story to repeat, meaning after the acute phase, after the pandemic is over, all systems are collapsing, all the capacity we built went back to the level pre-pandemic. So really this moving ahead past these acute phases is a challenge, but for this pandemic, things are going far better, mainly because of all this pandemic accord negotiation, VIHR revision. I think the world now understood, because this pandemic was much more serious and has caused much more deaths than the previous one, that we need to do better. There is a way, sustainable financing also, with the pandemic fund coming into place. We have really a huge involvement of Gates in serosurveillance. You have seen that. So there is really, the global community is ready to do that. Now it's the coordination, so that doesn't go in every direction, and that all the funder, the partners really reunite between themselves and work together to achieve the same goal. So this is much more the issue, but definitively we have tried to work with GloPID-R. I don't know if you know them, because they are much more the finance, the organization that is trying to take care of this operational research aspect. But talking to them, and perhaps they are GloPID-R representative here, they are much more into the research itself. Not serosurveillance is something in between. Yeah, for us in WHO, we need to solve this problem. For your second point on the use of residual blood, my experience during COVID is that it was a system that was existing in some countries, but it was a system that was working. I don't know the Canada context, but was working much more as a, let's say, vertical program. And sometimes the connection with the much more routine surveillance program was not existing. It was much more, let's say, for HIV, for other purposes, I mean, in low-middle income countries or things like that. And there was some silo that needed to be broken, and that was the issue, because we could do so much. I mean, in terms of cost investment, with the bias we know about residual blood donors, but this is something that is definitively worth investing.
Great. Well, listen, thank you very much. Thank you to our panelists for another stimulating session. Thanks, Isabelle, for joining us from Europe. All right. And we'll move on now to our next session. Thank you.
Thank you.